panel today is going to be on innovative models in care coordination. We're very excited to have Bridget Kolb, who is Executive Director for the Institute for Quality Healthcare from LA, down here to facilitate the panel. Bridget has over 20 years of healthcare technology and public health administration experience working with community clinics, health plans, and hospitals. So please join me in giving her a warm welcome. Thank you.
Good morning. And thank you. Thank you to the association. Really appreciate the invitation. I'm happy to be here. IHQC is a small but mighty nonprofit based out of Los Angeles that provides training programs and facilitation and capacity building for safety net providers. The bio you can see, I always get teased about how does an engineer end up in public health, but your morning speaker, I think, addressed some of the benefits of having a solutions and a technology mindset for things, leading to those aha moments, and that's what we live for within IHQC. How do we help bring aha moments to you? And so today, I'm honored to have a panel of folks who have so many important and deeply experiential opportunities for you to have those aha moments about care coordination. So I'm just going to set up a few bits of scenarios for you and a bit of information and then turn it over to my colleagues here at the table. So care coordination and the models. So our agenda, we're just going to set the stage in the environment, but then we're going to talk about it in terms of three phases. A local perspective on care and case management that Dr. Norris is going to provide for us. The regional perspective that Jessica Fonte has graciously jumped in when poor Sharon Williams got stuck. Lovely airports and other things, and time being what it is. So a big hand of applause for Jessica to step in at short notice. Thank you. And then you're going to get a national perspective about experiences associated with leveraging data and shared language. So a really robust group here. So care coordination, I think we all can agree, is only a small percentage of the medical aspect of healthcare. This slide is from Schroeder back in 2007 talking about it, and we've seen variations on this as far as is the medical side, is the healthcare side only 10%, is it 15%? Either way, it's only a small slice of the pie. The pie is much bigger and has to be thought of beyond that. Just those aspects. Delivery is important, however, everything else that impacts your patients' lives, your community's lives, then go to that overall care. And all of those, in order for us to look at improved outcomes, improved population health, and how to manage those costs that we're very concerned about, has to go beyond just the direct services. So, when we think about it, and this is another model, another visual for you that was out of the May Health Affairs, when we think about and we hear the phrasing about upstream and midstream and downstream or direct services, think about it in terms today of, with downstream being providing those direct care, those medical interventions, we need to move further, and we're starting to move midstream and starting to consider the social impacts. We're surveying and assessing folks as they come through our doors in various capacities and across multiple doors. Use hospitals, primary care, social services, et cetera. Even further than that is fully the upstream, and how do we then think about policy change and addressing some of those before these things can happen? How do we work through, and we had a fabulous conversation at dinner last night about how do we address some of these issues when there's local regulations and state regulations and federal, and how do we make those coordinations? So it's a quagmire. We basically need a mosaic of services and start thinking about those and how do we coordinate. So for better or for worse, there already is a mosaic of services here in San Diego and Imperial counties. However, quite frankly, and I think you all know this, I'm not going to show you anything you haven't already experienced, is the mosaic pieces don't make quite a clear picture yet. Multiple delivery systems, more than 160 community health centers, 38 hospitals and health systems, multiple support service providers, all doing your due best to provide services. 7 managed care health plans with varying eligibility, network standards, expectations, as we all know. High default rate 35 to 40% for falling off Medi-Cal and then being auto-assigned to care providers. Where did their data go? Where did their information go? We're starting the clock over again as far as provision of services for them. And then 3 information technology exchange systems across the county and structure, differing access points, differing data elements, and differing flow. So definitely challenging services across different delivery mechanisms, medical side, behavioral health side, and other delivery structures. So this mosaic is there. Now how do we coordinate and intersect between them? How do we make this not so much a spaghetti flowchart with the noodles thrown up against the wall? Lots of efforts already in play, regionally, statewide, and nationally. Patient-centered medical homes, defining social determinants and screening for those, accountable care, complex care management, whole person care. For better or for worse, all of these are efforts to try to incentivize, encourage, move folks to those better streamlined care coordination efforts, prioritize those outcomes, like Nicholas had said this morning, about looking for those quality care and how do we get there. So looking ahead, there's also, as we're hearing and reading in the CalAIM work, there's going to be higher and higher expectations for care coordination and improved outcomes and cost tied to that. Those expectations as far as enhanced care management, investments in lieu of services offerings, and how do we bolster up the communities that we've got. So while we've got this mosaic and while we've got these opportunities, I want to turn you over to our panelists who are going to give you this sense of perspective. We're going to start at the local level and get that sense of what it really is from Dr. Norris about care and case management from the front line. The regional perspective, and Jessica's going to share with us some of their experiences in successful lessons learned, promising practices around the health homes model. And then nationally, Sheena's going to share with us how there may be good structures and also promising practices about data sharing and shared language. So let me turn this over to Dr. Norris, Medical Director for Father Joe's Villages.
So I'm Jeff Norris. I'm the Medical Director at Father Joe's Villages. I run the federally qualified health center that is embedded within Father Joe's Villages. Father Joe's is a very large social service agency for those experiencing homelessness that provides a large continuum of services from residential, case management, a day center for those on the streets, food, and a variety of other services. And the health center, the FQHC, is one of those many services that are available at Father Joe's. And I'm going to talk a little bit about what care and case management currently looks like within the County of San Diego, what some of the gaps and issues are with the current system that we have put in place or systems we have in place, and then where we can think about going and some ideas as we move forward to improve the current landscape. So as we think about where we are right now, if we look at the pyramid of need and complexity of care and case management issues here in San Diego, our current programs, the main programs, there's certainly more than these two, but the main programs that we have currently are health homes and whole person wellness. And these programs, by and large, focus on those with medium complexity care and case management needs, and a little bit of those folks who have higher complexity care and case management needs. For a little bit of background, just if you don't know what these programs are, Health Homes is a care and case management program where health plans, Medi-Cal health plans, are the payers. They get funds from the state that are then passed down to the health plans and then to care management entities. It's a Medi-Cal benefit. There are certain criteria that the state has set up that individuals have to meet in order to be eligible for this program. And then the actual service delivery system is provided by what are called CBCMEs, community-based care management entities. Whole person wellness, in contrast, also known as whole person care, is a little bit different. The county is the payer. The money comes from a Medi-Cal waiver at a state level. And there's a lot of lack of clarity about the future of this program. There's back and forth. It seems like every week or every month things change at a state level about what the future of this program is. And the care delivery system is through what are called service integration teams, or SITs. So these are the nonprofits, the community agencies doing the actual work to do the care and case management day to day. Within the system, there's some serious gaps and issues, though. One of the biggest current gaps is that the current service providers, generally speaking, don't provide round-the-clock access and services. We all know that EDs and hospitals function 24/7. The needs of individuals in the community who have care and case management needs don't stop after 9 to 5, Monday through Friday. Some of these programs do operate on the weekend, but very few, and even fewer have access overnight. And so when a hospital is working with an individual who has needs after hours, there's not that glue that keeps the care connected together. I like to call care and case management systems the interstitial space, to use a medical term. If you don't know what the interstitial space is, it's the stuff between the cells in the body. It's that stuff that kind of glues the cells together. And the cells in this case are hospitals, clinics, social service agencies, all the folks doing the great work throughout San Diego and Imperial counties. And the care and case management programs are that glue. It's what keeps everything bound together. And you can't bind things together just during business hours. It's not going to work. That's not a functional solution long-term for everyone. There's also a lack of personal connection very frequently between the care and case managers, hospital and emergency department staff, other providers, social service agencies. We don't know one another as well as we should. We don't know that John is at that emergency department, know his phone number, be able to pick up the phone when a patient shows up and make a connection that's personal to provide better care and case management. There's also a lack of what I would call true value-based care reimbursement within the current models. Most of the current models are focused on fee-for-service and capitation at a very flat rate that is not risk-adjusted, and there's no upside or downside risk in the current models. And if we're talking about real value-based care, that's where we need to be moving. So the models are not quite there in terms of how we're reimbursing providers. And all of this is really driven by a couple of things. The first, that there isn't sufficient funding to provide care and case management for the highest risk individuals, the top folks at the very top of the pyramid of need. The money just isn't quite there in the current structure that we have. The second is that there's a huge number of providers, as we just talked about, within San Diego. This is a complex healthcare market. This is a complex social services market. There's a lot of people doing a lot of things that overlap, all with good intentions, but there's a lot happening. And that makes it difficult for everyone to stay connected. It makes it difficult to develop personal connections and make sure the folks doing the frontline work are able to communicate effectively with one another. And then the last big piece of this is the inconsistent use of information exchanges. This is kind of like the interstitial space of data, if you will. It's what binds all the data together. And Nick, of course, was talking some about this and trying to utilize big data more effectively while also keeping in mind privacy concerns. And because different people are using different tools in different ways and inconsistently, that means that our ability to leverage these tools to really communicate effectively is severely hampered within San Diego. And this is something that's being faced around the country. I don't want to say this is a San Diego issue. It's really a national issue, truly a global issue. I've talked to folks from even England, where they do have single payer, and they have some similar issues, especially with social services data. And then when we look at the payer side, as was just mentioned, we have a large number of payers. And with that comes a variety of approaches to a number of different things. Reporting and documentation vary vastly between payers in these case and care management systems. And as I reflect on what Nick was talking about around sameness and differentness, I would say that when it comes to reporting and documentation, that's not a place where we should have differentness. That's not a place where differentness results in increased value. I'll talk about where I think the differentness should occur, and it's not here. There's also a variety of approaches to cross-matching with other care and case management programs. What I mean by that is an individual is not supposed to get services from both health homes and whole person wellness at the same time. And payers right now are taking a variety of approaches to getting data to the care management entities about who's enrolled in what program. And so that makes it very difficult to know what's already being provided, who's doing what in the community, and difficult for us to be that interstitial space and pull everything together. There's a variety of approaches to consenting. Some programs require in-person consent, some allow for on the phone, and that variety of approach is challenging for providers. And then there's also a variety of approaches to payment for outreach, even if a patient doesn't sign up for services. What that means in practice is that I, as a person who's running a care management program, am going to go after, because of the financial incentives, folks that are easier to engage with, easier to enroll in these programs. Because if not, if I go after the more challenging folks to work with, I'm going to do a lot of work and spend money that I don't really have, I'll just put it that way, at Father Joe's, to try to engage somebody, have that financial outlay and that financial loss and risk that we can't necessarily take on. So there has to be more consideration of how do we make sure that we are getting services to the right folks and engaging and enrolling the right folks who really have needs. All these issues really drive a couple of things. They increase administrative costs substantially. They mean that we spend more money on more of the infrastructural part of running these programs rather than the actual service delivery component. And that results in increased rates of burnout, increased rates of frustration on the parts of providers doing the care management, but also hospitals and other providers in the community. We feel like we're not actually doing the work that needs to be done as much as we would like to, and we're spending more time reporting, documenting, et cetera. Of course, as we look at healthcare as a whole, this isn't something that's unique to care and case management. This is a challenge in healthcare more broadly. These are the discussions around burnout and provider wellness and how do we improve the entire system. So these issues are really a microcosm for the larger macro system of healthcare more broadly. Within these gaps and issues, providers have really tried to come together to try to develop workarounds. We've been meeting on a very regular basis, both as providers and then also with health plans and the county to try to improve the way we provide these services. But that is, again, increased cost, increased time, investment to try to get over this differentness that perhaps shouldn't be there because it just leads to extra cost and not increased value within the system. So as we then reflect back on that pyramid of the levels of need and what's going on currently in San Diego, what we start to realize is that the current state has significant issues. When we talk about health homes and whole person wellness and these challenges, we've got some things we need to work through. And it also means we're still not reaching the top 1% to 2% of folks, the folks with the highest level of need, the most complex patients for a variety of reasons. And I do want to reflect now back on a prior program that did surmount some of these issues and reflect on how that could influence and guide us as we move forward. And it's a program that existed at Father Joe's Villages. I'm sure many of you are familiar with it, called Project 25. Project 25 was a high-risk case and care management program that really focused on the highest of high utilizers in the county of San Diego. These are the folks that were in the ED, hospital, jails almost every day of the year. There was an individual that I remember very well who had only been on the streets for about 1 to 2 weeks out of an entire year, and the rest of the time he was either admitted to the hospital, in an ED, in a jail, or some other institutionalized setting. So the joke around this was, well, he's not really homeless. That person's not homeless because he's only been on the streets 2 weeks out of the year. Of course, that's a joke. That's not the reality. But it exemplifies how much was going on for that individual and the complexities that are inherent to doing case and care management for a patient like that. The program started in 2012. Funding was initially through SAMHSA and the United Way, and then transitioned to the Medi-Cal health plans paying for the program. This program was shown to save $2.6 million for 28 participants in a single year from 2012 to 2013. That's almost $100,000 per individual per year in the first year that this program existed. Extrapolate that over time. Think about how much savings there is for the system, and then the improvement in health and well-being for those individuals that are receiving services through that program. Unfortunately, this program has wound down as other programs have developed, as health homes and whole person wellness has ramped up. But again, I think Project 25 is inherently different, and I'll talk a little bit more about why. It also wound down as the approach to oversight changed as Medi-Cal health plans got involved as the payers. So why did Project 25 work? Project 25 function so well? What was it about this program that worked? And I think this actually dovetails very nicely with what Nicholas Webb was talking about. The main thing that was different was that the payers and the grant funders really allowed for a truly patient-centered approach. The motto was really, as long as it was legal and ethical, do whatever's necessary for that individual to get their needs met so that their health improves and the costs of care for that individual go down. That resulted in an unparalleled level of service here in San Diego. It involved daily touches, sometimes multiple times a day. It meant sitting with somebody for hours at a time, potentially the Social Security office or the DMV, or for an appointment, whatever that might look like. And it involved a very heavy focus on harm reduction. The best example of that was an individual who was dying of cirrhosis and was not going to stop drinking. Didn't matter who said what we did, motivational interviewing, didn't matter. He wasn't going to stop drinking. So he went on hospice with a 6-pack of beer a day, and he died in hospice rather than on the streets drinking a half-gallon of vodka a day. So sometimes we have to redefine what success looks like, but I would say that's success. It also took a very, very strong focus on housing first, to say if we don't provide housing for individuals in a program like this who are on the streets, we're not going to be able to make a difference with their other health issues and decrease the cost of care. It's just not going to happen. That has to be at the core, and housing vouchers were a piece of that. And that's a piece of what's currently missing in our current care and case management programs. Reporting was also as minimal as possible. There weren't heavy reporting requirements. Really, the reporting was more focused on outcomes. It was on decreasing utilization, decreasing costs of care via that, and increasing housing rates. It was about making sure that those outcomes were being addressed. It also had a very heavy focus on leveraging relationships with hospitals and EDs. The care and case managers in Project 25 knew personally the social workers, RN case managers at the hospitals and in the emergency departments. So when that individual showed up, they picked up the phone, called on speed dial, P25's case manager, whoever that was, and started making things happen. Now that's challenging with our current environment with so many different providers, but we need to be able to make that happen. The other piece of this is that Project 25 was closely aligned with a federally qualified health center, a provider that could do primary care, behavioral health, psychiatry, et cetera. There has to be a connection between social service programs like this and healthcare. And we're moving that way with health homes, which is generally provided by FQHCs, but there needs to be more work around this. Now, as a general caveat to this whole program, you can't do this without more money. The current programs don't have enough money to do this kind of work, fully acknowledged. The money that paid for P25 was almost, not quite, almost an order of magnitude greater than the current funding for current programs. So what this is this is a question as we look back at time about what we have done that's worked and has not worked. We really have to think about where do we go from here and how do we restructure programs, restructure the funding sources so that we can make sure we meet every individual's needs as best we possibly can, decrease costs, and improve health within our community. To really drive value is what this comes down to. So the last thing I'll say with Nicholas Webb's words bubbling around in my head is the differentness in these models really has to be in the flexibility that the system allows individual care management programs, individual case managers and care managers to do the work that needs to be done to meet individual patients' needs. That's where the differenceness needs to occur within these systems. Thank you.
Thank you. So next we're going to hear from Jessica Fonte. She is the Senior Health Home Transformation Consultant with United Healthcare. And Jessica?
Hi, good morning. Thank you for letting me be here. My supervisor, Sharon Williams, is out of Seattle, and as they said, her plane was held up, so I am in her place. She is our Regional Director for Health Homes and has been running a successful health home program in Washington State for many years now. So this is her deck, so thank you for allowing me to present it today. So Health Home Model is an integrated care coordination, and it's based on a few core pillars, so one of which has been the highlight of today's conversation, is relationships. Practice cultural competency so clinicians mirror members and experiences and language. Clinical quality. Implement high-quality, repeatable care coordination, service delivery, quality and cost. Continuously seek approaches to contain costs and achieve healthcare savings. And measure meaningful outcomes, capture and communicate success stories. So this is, again, about the pillars of the Health Home program and the different ways that we do deliver those services. So there are care coordination, which is across system activities to help participants access and navigate needed services. Care transitions, proper and timely follow-up to help prevent avoidable readmission after discharge from ER and inpatient facilities. Referral management, identification of community-based resources, and actively managing referrals, advocating for access to health, and engagement support, social supports related to the Health Action Plan, which is commonly referred to as the HAP in this program. Health promotion begins with the HAP commencement and demonstrates use of self-management, recovery, and resiliency principles using person-identified supports, and also addresses care gaps. Individual, family, and caregiver support provides support to access and navigate healthcare and social service systems, along with the Health Action Plan support. So on this slide, you'll notice it says care coordination organizations. That's what they're called in Washington. In San Diego, we've labeled them CBCMEs. And they provide accountability for care coordination services and care team organization to our high-cost, high-need population members. So relationships, that's the core of what this is all about. Maintain solid connections with members and providers, fill in those care gaps. So align diverse provider types and services to match member needs, practice cultural competency, so clinicians mirror members' experiences and language, and build lasting relationships based on trust and integrity, and through consistent value-added interactions, allow with best practice methods, such as trauma-informed care and motivational interviewing. Quality clinical intervention, practice outstanding care coordination. Ensure timely and quality care transitions, implement weekly interdisciplinary rounds with medical and behavioral health teams and community staff with social service knowledge. Facilitate clinical services and identify areas to improve clinical experiences. Quality and cost, low-cost savings and low-cost services and healthcare savings. Move care coordination services to member-centered places of service, such as their home or their identified place of service. Identify high users of intensive services, including those using ER for avoidable reasons, and address member needs. Leverage existing infrastructure, processes, and practices to offer low-cost, high-quality clinical solutions. Meaningful outcomes. Relevant population health reporting. Measure what matters. Establish methods to collect accurate and relevant outcomes that add value to regulators, stakeholders, and providers. Provide actionable data. Allow for continuous improvement or changes to reporting requirements based on regulatory requirements or innovation. Capture and communicate success stories. So we have one of those success stories to share with you today. This is from a member from Washington State. The member is a 63-year-old male Spanish-speaking U.S. citizen whose only familial support is his wife. Member is disabled, unable to work, depressed, lacks motivation, and overwhelmed by conditions. He and his wife live on a fixed income of $735 per month. Member's wife, also Spanish-speaking, serves as a full-time unpaid caregiver and has struggled to manage his complex care needs and coordinate provider services. Member's assigned care coordinator is fluent in Spanish and can connect culturally and linguistically. Member has a primary care medical provider and behavioral health provider. So general health conditions include type 2 diabetes, sleep apnea, end-stage renal failure, major depression, dementia, and pain. Some of the treatments and interventions provided by the care coordinator, orchestrated by the care coordinator, dialysis, PT, dental, medication reconciliation, counseling, DME, HUD housing, food and nutrition, and transportation. So after enrollment, the Health Home Program member, wife, and care coordinator jointly attended every appointment, resulting in reduced PHQ-9 depression scores from moderate severe to minimal. Member accesses multiple services for his chronic conditions, receiving much-needed preventative care and treatment. Care coordinator has helped with access to community resources, ensuring member remained on public assistance for housing, has food and nutritional benefits, and access to free transportation. So the outcome, reduction in ER IP utilization by 50% over 18 months. So in summary, putting this together, the Health Home Program is really built on relationships, quality clinical intervention, which provides improved quality and cost, and meaningful outcomes for our individual members.
One, thank Jessica for picking up the slide deck this morning and running with it. Couple questions, but forgive me, Sheena, I'm going to pause for a moment. For both of you, so you've seen successful models as an organization. You've heard about them, about the Washington experience at a regional level, implementing all of those pillars that you've described. What do you see as opportunities for lifting those best practices and applying them here in California? What would you prioritize if you were given the magic wand to make all those decisions?
Absolutely. Well, a couple of things. I feel really lucky because due to Sharon and the Washington Health Home team's experience, they've had over 5 years of success where they can take all of their lessons learned and their successes, best practices, and they package them into an implementation project for us, which I just got to walk into. They did all of this work, they learned all these lessons, and we get to implement them here in San Diego County. I think one thing that's really exciting is as I tell them the steps we're making forward, and I see their eyes light up and they say, oh, they're getting it. Like you've just barely got your toe wet of what this program can be. So I'm really excited to see it unfold. So I think the biggest thing it's gonna take is time and spreading the message until our whole county is used to this program and when to refer and what to do with it, and it's just gonna take time.
And then you mentioned earlier, obviously, successful adaptations of programs, Project 25, some of the health homes, whole person care, but also the workarounds that you've had to employ, basically, because we need time. We need to build those relationships. What's a good example of a workaround that you've had to use?
So I think that the biggest work that we've had to create workarounds for is trying to make sure that we're not duplicating efforts with whole person wellness and make sure that our work with health homes is aligned with health homes. I think that the biggest challenge I see in healthcare for the homeless and social service programs here in San Diego is that we have a lot of programs and we like to start new programs and pilot new programs, which is great. That's innovation and we should be innovating. But as we innovate, we need to make sure that we're not duplicating, triplicating, and those programs dovetail and work effectively with what we've already got. And then find those things that work, and we have these conversations all the time with among leaders here in the community. We need to then scale those programs that work and make sure that we let the things that work stick. So a lot of the workarounds have been about managing just the complexity of our social services and healthcare services market, and trying to make sure that we're not breaking the rules. That's really what it comes down to. And I always say that the thing that we should make same, if you want to use Nicholas Webb's terms, and we should keep as similar as possible, are the things that reasonably should be on the administrative side, because our patients, our clients, our customers, whatever you want to call them, their lives are going to be chaotic. And we can't spend our time spinning our wheels on the administrative stuff and let that suck our emotional and intellectual energy. Because if we let that happen and let that become what it's all about in developing workarounds, we're not going to have the energy and the wherewithal to deal with the chaos of our customers' lives, because their lives will be chaos no matter what we do until we can end homelessness. That's when the chaos starts to slow down. That's going to happen, I firmly believe it, but that's going to take a long time and larger structural policy changes at all levels of government.
Thank you very much. All right, now to the national stage. Sheena Nam McKinley is with us here. She's the Vice President for Research and Development with Health Leads.
Thank
Sheena.
you, Bridget. So before I share a couple quick snapshots of interesting things that we're finding in places all around the country, I wanted to center a little bit on the work that Health Leads does and how we came into these lessons and learnings with partners. So at Health Leads, we're really focused on understanding how to advance health equity so that every person, every community can achieve health and well-being. And historically, what that has looked like was the bridge building between healthcare, community resources, and the patient to find resources, referrals that they needed, and to get connected. And I think over the course of time, we're still obviously facilitating that work, but over the course of time, we also came to understand, patients need to be able to choose the resources to find, know where they are, and also using that data, we need to be able to look at barriers systemically that are preventing them from making the choices that they want to make. So I'll share a little bit about some of the interesting ways that we've been able to leverage data. We often look back at sort of the arc of our work and the work of our partners around the country as this movement from Health 1.0 being more of a sick care system, Health 2.0, where we sort of entered the scene. And at the time Health Leads started 20 years ago, it was a big task to push for even the formal integration of social needs screenings. And the big question, I always track kind of how questions shift over time and how anxieties shift and energy shifts over time. And so the question then was, how can we solve the problem of just regular screening adoption and enrollment and intake, right? And the uptick on enrollment. And that was a lot of the research being done. Fast forward now to a great number of health systems already having some kind of formal program or protocol around social needs screening. And where we're at right now in the years looking forward in Health 3.0, in terms of understanding what happens afterwards, right? As you navigate across multiple systems, what are those barriers? And that necessarily requires going outside of the hospital walls and partnering more deeply with community stakeholders, whether that's community-based organizations, residents, consumer advocate groups. So, and we see this in all of the healthcare news, and some of the interesting things, again, I've noted are really trying to understand what ways that partnerships can collaborate better, right, to address those barriers. So I want to start with an example to the north of us in the Bay Area and talk through the Benetech ServiceNet. And so we're one of many participants in a pilot project in technology to connect I call it sort of the plumbing between all of the silos that are springing up. So on the one hand, it's been so exciting to come from a space where there wasn't even regular screening of social determinants of health to now the space where you see so many resources, a lot of great labor and effort around creating resource databases, finding the right platform to support resource and referral. And so you can imagine, right, even in one specific region or area, like the Bay Area, there are multiple teams regularly working really hard to make sure that those resources are up to date. So eligibility criteria, hours of operation, just some basic things like making sure that building is actually still there. And so teams are working really hard on this, and also, which is exciting, and also from a distance, it creates the danger of a lot of duplicative effort and a ton of inefficiency, both at the cost level and just in terms of frustration and the creation of more silos. And so what the Benetech ServiceNet is doing is basically creating a platform where multiple participants and systems are able to upload all of their recent resource updates, and then you can download from that ServiceNet any recent updates. Why that's really valuable is, let's say at Health Leads, I have a team and they have recently made, because of our partnerships with pediatric clinics, have made a bunch of updates to WIC and to early education resources, right? Meanwhile, we have another health system in the area that has their own platform, their own incredible team, and we know that they've been making a ton of updates to housing, right? And eventually our team may also find out about those updates because of staff telling us, or maybe CBO partners, and we'll get around to that. But what's happened is we've already made those updates, and wouldn't it be great if there's just a way that without our team getting around to it, we benefit from the housing updates that one system made, and that system benefits from all of the early education resources that we've updated. So this platform is currently under pilot process, and I can share a little bit more too about some of the tests that we're doing around trust, even within resource sharing. One of the interesting things here is, and this is currently being tested, is we noticed that some of those updates were not necessarily being accepted from the platform. And so trying to understand right now, the updates just has sort of a timestamp, like resource for early education updated November 13th. Right, and so if we add additional information, like resource was updated from Sheena, from Health Leads, and these are the corrections or the revisions I've made, does that increase systems sort of agreeing to download that data? So it's one thing to participate in that, and then to regularly trust the data that's being shared in a more efficient manner across systems. And some of that is relational. If you know me, or if you know, let's say, our organization and our practices and how often and the level of quality or detail that we hold those updates to. But some of it might be you don't know us, you don't know our organization, but it's really beneficial to say what they updated was eligibility criteria. Okay, that's a huge issue in our system. I need to download that. moving across the country and a little bit more downstream from the resource, or a little bit of a different lens from the resource updating problem or inquiry that we're having in the Bay Area, we just finished a long-term research project with Health and Hospitals in New York and also their WIC program. And Health Leads was facilitating and managing a community health worker-run program in the clinic. And through collaborative conversations, they recognized that there just wasn't as much WIC enrollment based on the amount of folks that qualified. And so because we shared a data platform, we were able to look at both quantitative data, where were the drop-offs, and some of it was just really clear. It was between the initial outreach and the checking of eligibility and a lot of the confusion around that, and then another giant drop-off between referral and submitting an application. And then also importantly, because we partnered with caregivers that were more proximate to those lived experiences, the community health workers, they were also putting some pretty standardized qualitative notes and case notes, and we were able to look at some recurring themes around the journey map, right, of patients and finding out where there were problems, right? And what was interesting was some of the recommendations that came from collaboratively interpreting those data together and coming up with recommendations was, in part, it was really practical, and sometimes revolution is in the very simple, obvious things. So some of it was just program operations, revisions, creating same-day walk-in appointments for WIC, and right. Making sure hours of operation were in coordination between the clinic and WIC staff. And then some of it was leveraging existing policies that had not quite been implemented in a standardized way. So for example, the state of New York already has passed some more progressive policies around temporary certification or temporary enrollment into WIC if you're missing a single document for about a month, right? And so you are able to enroll even if you're missing that document, and a lot of sites just didn't know that that policy existed, or maybe we're operating from an older policy manual or piece of information. And so that was just a matter of taking existing policy and also recognizing that that's where one of the barriers were from a patient perspective, and then implementing that across all of the sites. And then finally, and this is currently under review statewide, is a recommendation around auto-enrollment or auto-certification, which is a little bit of a misnomer. It's really more about patient choosing whether or not they want that resource, but proactively, right, through shared data systems and network partners, proactively reaching out to, a woman who's pregnant with Medicaid to say, you qualify for WIC, would you like to enroll, right, and doing so earlier in the process. So that's New York, rounding, not quite a full circle, but coming back to the West Coast. Here in San Diego, it's been really exciting for our team at Health Leads to be in conversation and learning so much more about the community information exchange, where you have the benefit of multiple partners and cross-sector relationships, facilitating, right, a lot of the connections to resources and conversations that are supporting a whole person outside of the hospital walls. And, I think we've been seeing a lot of movement. There's some great early adopters across the country. There's, similar models starting to bubble up in Oregon and other places across the country. Really interested not only in bidirectional resource referral platforms, which is great. 10, 15 years ago, that was like wild child to be able to say that. And not only interested in the technology and the resource and referral systems, but also in really understanding what shared language looks like in a community exchange like that. And the example that bubbles up in my mind is a story a friend of mine shared where her teenage son had lost PlayStation. I don't even know what the cool gaming softwares are now, but he had lost video gaming privileges and texted her, when do I get access back? And because she's also like a 21st century educator, she responded back, Google how long it takes to develop a new habit, right? And he responded back shortly, and he said, "Oh man, I can't wait 66 days, right?" And so, I mean, this is just sort of a real life example, but I think about that because I've been in so many rooms where there is great energy around, we need to have shared language, right? And maybe there's some co-visioning and a shared value around really addressing the needs of the whole person and being trauma-informed and all of these incredible things that do need to happen, right? Where partners agree and have that shared language and those shared values. But what does it take to actualize, right? To make into behavioral practice shared language, right? And so when I think about those 66 days, right, to maybe do homework, I also think about the amount of time and repetition and systematization it takes to develop this habit or practice of shared language. And so when I look at the CIE and tools, not just in the infrastructure of the platform, but the tool of like the risk rating scale, where any practitioner or service provider that's participating is able to look at these 14 social determinants of health to be able to screen across a longitudinal record, right, on a scale of crisis to thriving, and to be regularly looking and inputting on all of these multiple domains, this range of being, right, toward well-being, the knowledge of resources and some of the barriers and supports that facilitate that. To me, it is putting into practice what a lot of people would say, sure, shared language, right? I don't often enter rooms where they're like, I don't like shared language, right? I think it's actually just a great model of making that really practical and really user-friendly. And then also on the back end, what's really interesting there is the ability to pull data to make the experience, right, more relevant, both for individual clients and also in a population health perspective, right? And really understanding what broader trends are occurring for specific zip codes, neighborhoods, people within a given region, and to understand how collaborative efforts and be able to track those collaborative efforts might be held accountable, right, on a population health level. So with that, I'll turn it over.
So let's thank our panelists, if we could. Thematically, what you're going to hear, what I heard, and what we'll run through the rest of the agenda today as well. The interstitials, how do we bind ourselves together? The plumbing that'll get us there. The time, the guidebook, lifting appropriate procedures about what's worked in areas that can work here. The optimism, we can do this. Let's try not duplicating efforts. Let's look at ways to scale up and get them to stick. How do we proactively leverage this information that we do have access to, that we can, in fact, build structures around to share, and look at those above and beyond just the clinical outcomes, but also to what are the bigger needs. So from all three of you, I thank you for your time and the prep and the conversations we've had. I'm going to roll this out to all of you. I'm going to stop hogging them because I could pick their brains all day. They will also be here for you to pull aside over lunch and the like to assist. So what questions do we have from the floor?
Hi, I'm Melody Thomas from Scripps, and just curious about, again, the integration with CIE and health homes. Is there a way that we can, again, kind of make one step to say, look, we have all these programs that are already up and running, that the data is available, to make sure that we are putting the data we already have into a system we already have?
So I think that as we look at information exchange tools, those tools are only as effective, and I think this is what you're getting at, they're only as effective as the data we put into them, the quality of the data that goes in, and then the usability of that data. And that's not something, obviously, that's an on or off switch. It's not something that happens immediately. That's a process, that's a road, that's a journey, and it's a journey that many of you in this room have been on, and have been on for a long time. But I think the key message is we can't give up on that journey, despite the frustrations, despite the challenges, despite the challenges of HIPAA and 42 CFR and the legal side of things. That fight needs to be continued. Otherwise, we're not going to get there, and it's not an easy road to be on. So I would just say, please stay on that road. Don't give up on that road. Don't take a U-turn and go backward, because otherwise we're going to lose everything, and the I don't know how many million, probably tens of millions of dollars at this point that we've put into these efforts. So we can't lose what we've already gained, and we need to keep driving.
Good morning. I'm RJ from Case Management from El Centro Regional. Last week, we had this homelessness policy workshop in Sacramento, and some of the counties share their best practices, and obviously, this SB 1152 has been a challenge to every facility, and obviously, based on Dr. Norris' presentation, that housing is a priority, and for Sheena, housing stability, right? I just wonder if San Diego County or Imperial County is doing the hotel motel conversion, because that has been shared by, I think if I'm not mistaken, San Bernardino County as their best practices, because the way they approach homelessness is basically to house them first, then implement the program. So I don't know if we have that similar program here in San Diego County and Imperial County.
So the answer is emphatically yes, that absolutely is happening here in the county of San Diego. There's a number of organizations that are doing that work. Father Joe's Villages is one of those. We're getting very close to potential closure on a property in the southern part of, in the south region, to do exactly that. As we look at homelessness, there's many different components and causes of homelessness. The base of it is increasing housing prices and stagnant or decreasing wages adjusted for inflation. But a piece of that housing puzzle is that we have lost tens of thousands of units of lower cost housing here in San Diego, and part of that has been SROs. And as we look at these motels and hotels, if we let these get swallowed up by developers and developed into luxury high-end housing, that's only going to make things worse. So this has to be a component of the solution. So the answer is absolutely. But then the key is, I think, making sure that as folks get housed in those programs, you can't just house folks and leave them without anything else. You have to connect, you have to have that interstitial space, you have to have the care and case management, you have to get them health care. It has to come as a package of services, individualized to the individual, but you have to do it all. So the answer is yes.
Question over here?
Dr. Norris, I just wondered, at Father Joe's, are you seeing a lot of homeless that are due to behavioral health? And if so, are you seeing them cycle through, coming back and leaving, coming back?
Absolutely, and I think that really gets the challenge of working folks. These are folks that, generally speaking, end up in the higher acuity need for care and case management programs, and those folks do cycle in and out, and that's largely because our current capacity that is growing is mostly interim shelters, and interim shelters, by and large, are not the most appropriate housing intervention for folks with that level of need. I'm not saying interim shelters are not important, they absolutely are. But if we can't work on a longer-term housing arrangement that's more appropriate for individuals facing those challenges, we're not going to surmount folks with dual diagnosis, substance use disorders, and severe mental illness and other similar issues.
So your solution would be?
My solution would be we need to have we need to continue the road of improving the care and case management programs we already have. We need a higher tier program to reach those with the highest complexity need. We need to get back to that. We don't have that. That's a hole in our current landscape. And then we need to have housing funds for housing, whether that's packaged through the care and case management programs or accessible by those programs, so we can tap into those resources to make sure people can get housing beyond an interim shelter. An interim shelter is not going to solve our long-term issues. It's a stopgap, it's a temporary measure, it's a necessary temporary measure, but we have to solve the supply-demand issues of homelessness, of housing, and provide housing interventions that are more appropriate across the board. And we're moving that direction, but it's taking a lot of time, as these things do.
Next question's over here.
Thank you all for the panel. Enjoyed the discussion. Jack Daly, Legal Aid Society of San Diego. As these programs scale out statewide and as integrated models are studied at the state level, accountability is often one of the advocates' kind of bellmark and oftenly echoed request. And specifically in and around care coordination and case management, I'm curious if you have any best practices or recommendations with regards to ratios, varying depending on the acuity level of the individual, to case manager to the individual consumer. We found that number one problem we've had with care coordination and case management is that some people at the higher end don't know who their care coordinator is, and we see care coordinator case ratio to patient ratios as high as 350 to 1 in some metrics. So just curious to hear what your thoughts on the appropriate ratio depending on acuity.
Absolutely. So I'm a licensed professional clinical counselor by trade, so I've had caseloads that were astronomical, and I've been in the field and I've experienced that. So when I came on to the Health Home program, there are a variety of things I looked for. I wanted to see the program have manageable caseloads. I wanted to see that it was trauma-informed, and I was really happy that we work with the ACEs trauma-informed system. And that's exactly one of the pillars of this program, is it is supposed to be individualized, it is supposed to be personal, it is built on that relationship. And that's really one of the best ways to get buy-in is to legitimately care about someone. And you can't do that if you don't know who they are. So that really is one of the best parts of the Health Home program, in my opinion.
Just to add on a little bit from the lens of how technology might be able to adapt or facilitate that, we had an experience where, we had a lot of success using a platform for case management, right? And a lot of the problems that it had solved was, and there were a ton of data that informed good staffing ratios before there were any drops in quality of service provision, but a lot of the features were facilitating staff, making sure that they were getting around to all of the cases and not spending so long on a single case that they didn't attend to, let's say, the other 59 in their 60-person caseload. And so one of the features, this is just being really concrete, was sort of like days fresh or days stale, right? And a lot of the proxy process metrics that department administrators were using for effectiveness was sort of how many of the community health workers had seen what % of cases within a 10-day frame, right? And it would literally flash red if you were out of frame or if you dropped below a certain % of your cases being out of those days. Our research team went to, this was mostly a group of promotoras as well as African American health conductors, specifically working with a reentry population. And what they shared with us was that it's challenging to see all of your dashboards light up red because you're not moving through the cases fast enough when a lot of the folks you're working with need a little bit longer to establish trust, understandably, given a lot of the societal things that they've been experiencing. And that it wasn't a matter of quick transactions, but sort of long, discussions and building trust and rapport, both on the relationship level and also, holding this tension between, again, for the reentry population where there was immediacy and urgency if you needed access to filling prescriptions upon release, but then also this feeling, and this was from kind of patient ethnographic data, that you needed first to reconnect with family and sit on your porch and hear the sound of the cars passing by, right? And not just about, okay, I called you this many times, did you connect with this resource, how's that going? And while that resource is important, of course, that there was something else at play that would have facilitated productivity, effectiveness, efficiency than what worked. And it holds firm that it worked in a different situation. And so I love that your question was not only about the ratio, but sort of with the context and intersection of acuity.
Next question right over here.
Hi, this is Aaron, Tri-City Medical Center. Question is mostly about the community information exchange here in San Diego County. And how could that CIE support better care coordination? And the second part of this is, how is that different than other systems nationally?
So you can take the local perspective.
I'll take the local, So some practical examples of what that looks like on a local level, and we talk a lot about this in the context of health homes, is being able to have a single source of truth about who is providing what aspect of a person's care. So who is that person's case manager? What entity do they come from? and what's their phone number at a basic absolute level, so that when that individual shows up at a hospital or shows up 5 times at a hospital in an ED over the course of 3 days, the case manager, the nurse, whoever it is at the hospital can access information, call that number and say, hey, John, Jill's been here 5 times in the last 3 days. I don't know what to do. Can we talk about this? Is there something we can do? What are you working on? Were you aware of this? And start working on that partnership and better care coordination. So that's a basic kind of nuts and bolts piece that I think is absolutely essential, is knowing who's on point for what, which we often in this complex healthcare and social services framework don't. I can say that firsthand. I see patients 50% time still in my clinic, and I have patients who bounce back and forth between my clinic, family health centers, and other clinics. Multiple people are doing multiple things. They have 3 case managers all doing similar things, and I don't find out until something doesn't work out, and we're like, wait a second, they're over there doing that too? Well, and so we've been wasting money, resources, time, and effort, not for increased value. That doesn't result in improvement. So that's what, at a nuts and bolts level, a tool like that can allow you to do.
I think in similar models, I think it really is this example of proactive coordination between partners, and also being able to see where one lever in a sector that is not literally my business in a day-to-day kind of way is actually my business. And so, let's say you have a health system that's doing a referral for employment, right? But through a lot of the data and being able to share tools for language and looking at what's happening, you realize what's really a barrier is the transportation to the interview, right? And so that may not even have been part of the initial referral process, but you're able to kind of triangulate and sort of problem solve, in a very simplistic way of putting it, right, across multiple members in a given place.
Hi, this is Cammie Christensen with the Community Information Exchange in 201 San Diego, and so it's very exciting to hear all the references about CIE, and I did want to answer directly from CIE's perspective, and from the cross-sector impressions from FQHCs and from hospitals, and echoing what Dr. Nora shared earlier, is really validating the importance of sharing that information, whether you're an FQ and trying hard, and it does take 66 days to change behavior, and we have examples across our community, whether it's sharp going agency or institution-wide, and every single department has to change and has to reorganize, has to re-engineer the business processes, and it's frustrating and it's confusing, and it doesn't always work. When SB 1152 passed, it would be magical if you could log into CIE and make a referral for a bed. That's not where we are as a community, but CIE offers a longitudinal patient record, so that just the fact that that patient is in your ED is meaningful to the decision makers on when they're placing folks in beds. If we have scarce resources and you have shelter providers being able to see that history of care in CIE, that will change how they allocate those scarce resources. So I think, to Aaron's question, it really is looking at your institution, whether it's a hospital or an FQ, how are we currently using CIE, how can CIE serve us better, and have those really transparent, candid conversations, and build the trust. Because I think we have a luxury of having this as a resource in our community. Let's leverage it and use it in a variety of different ways.
Yes, hi. My name is Amy Adome. I'm from Sharp Healthcare, and my question is along the lines of the community resource directories. Dr. Nam, have you seen any efforts nationally for the CRDs to be connected directly into the electronic platforms? Because today it's a pretty burdensome process to have the clinicians look for customized or unique resource directories, because as soon as we update them, they change. And it's a management nightmare. So have you seen movement where these are being integrated directly into the big EMRs?
Definitely, and I think that's where it's been sort of this, like, I guess to use a local metaphor, this like incredible wave crescendo, where you saw some movement towards building platforms. And I think in the last, I think it was slow and steady for about 10 years, and then in the last 2 years, maybe even 18 months, a huge uptick in efforts and labor around Epic integration, the specific Healthy Planet module within Epic, when you look at Kaiser and their Thrive Local initiative and a lot of the ways in which this is being integrated, I think it's still, what's interesting to me about examples like the Benetech one that I shared is that that solves a particular systems problem. And to some extent, if it's integrated into Epic, then it solves multiple systems. But also, if you've got other entities doing resource and referral, something like what Benetech is trying to test is useful because of the problem that you're naming, which is all of the time and energy it takes to keep those up to date. And I think that the trust piece is that if you're working with community members who, who might give you a smaller window of time to trust the resources and to put their own time and energy into pursuing resources, it is really important, obviously, for all of those CRDs to be up to date.
Next question over here.
Dr. Norris, this is really directed toward you. Frank Pearson, formerly at Naval Hospital, Camp Pendleton. I thought this was going the direction earlier when you're kind of talking about bounce backs in particular and mental health cases. So I'm very curious as to, obviously, you probably, my assumption is you're not in a position to adequately place a lot of patients. So you're treating and treating, please excuse the colloquialism there, but so can you kind of address the dearth of mental health assets and from your perspective, what you see is needed and what is being done?
So obviously there's a severe workforce shortage when it comes to psychiatric providers, and that's a piece of it, but that doesn't deal with placement more directly. If we're talking about placement, I think that what is happening for folks with severe mental illness is similar to folks with higher need who have physical health issues. And that's that we don't have enough options in terms of housing interventions. I call it the social services hole. That's my term for it, and I think it's a national issue. I've worked in many states. Those of you who run hospitals know, or work in EDs know that this happens day in and day out. The patient that comes in that's a dispo situation. Well, where does the patient go? Dispo is probably the word to describe this situation. That's what we all face challenges around. And we do have to develop more capacity around this, but there's no singular intervention that I think solves that dispo issue, the patient that faces a dispo challenge or nightmare or crisis or whatever you want to call it. We have to have a variety of housing interventions and options for folks. The next speaker, Barbara, is going to talk about respite care, AKA recuperative care. That's one component of it. It's not the only component of it, but it's a piece of it. Talking about developing more independent living facilities, having more structure around independent living facilities and other similar options is important. And then the discussions around these bioethics discussions that are going on at a state level and at a county level and at a federal level around individual patient's choice, and when do we say that an individual is not able to make informed, rational choices about their health care and about their social circumstance. And that's a whole nother ball of yarn that I'm not going to get into now, and a much more complicated discussion. But these are the conversations and the issues that we've got to work through in order to improve the current situation. So things are headed the right direction. There's local energy developing around developing a housing funding for a local housing subsidy pool that's starting to gain a lot of traction, which is exciting. That'll help address this as well. So things are really, I think we're at the cusp of a change here in the county of San Diego, and in 5 years, because of you all, because of everyone in the county, are going to be in a very different situation. And I do want to underscore something. If we're going to make a difference on this issue and physical health issues, really all of this comes down to breaking down the silos between healthcare and social services. These two silos have existed separately and disconnected for far too many years. And everything that we're talking about right now, all of this is about breaking down those silos, not just building plumbing, but literally starting to bring those two sets of systems together. And that's where the value is going to be driven, is in those partnerships and those connections and that overlap. That's where we can make a difference.
Next question back here.
Yeah, Adrian Granda with Mayor Kevin Faulkner's office at the City of San Diego. Thank you guys. This has been a great discussion. I think there's been a lot of talk about, recidivism and folks kind of cycling through the system and making sure all the care is coordinated. Cities aren't traditionally a healthcare, partner, as part of those policy discussions, but we do run, many homeless programs through the Housing Commission and administer the vouchers through them as well. And my question for you guys is, what best practices or, what kind of role can we scale up, I guess, for cities and other government partners in this care coordination conversation? Because I think sometimes healthcare is kind of seen as its own animal, but obviously there's the jail system through the sheriffs, there's the DA and the public defender, our officers and first responders with fire rescue and EMTs that often see the same clients too and have their own databases that need to be integrated with the overall system. So yeah, I'll leave that there.
Best practice examples, how cities have engaged in other places that we might lift here in San Diego?
I mean, we can all say something.
They're all chomping. Wait. Let's start national.
Oh, okay.
Okay.
I mean, I don't know the state or the national level. I can say that I know the county has done some very diligent work around this with another information exchange platform that we haven't mentioned. And I apologize, Dr. Nick. I know he's in the audience. I can never get the name of the platform right. It says Well in it, and it's San Diego, but it's not Be Well San Diego. What? Connect Well. I don't know why. I can never remember the Connect Well San Diego. Thank you, Dr. Nick. So there's been some effort, and that pulls in data from jails and other sources, and is really trying to be a connector on that level. But as that develops, we need to make sure that's tied in with CIE, and we need to get over some of the legal challenges of making those things a reality. So I think there's already been some very seminal local infrastructure development around that, but absolutely, one of the challenges as we talk about decreasing costs of care is that the costs of care are so siloed in our system. And so the perverse incentives that are built into that are immense. A jail and a prison doesn't have any incentive to prevent somebody from going to a hospital because that cost and the negative consequence of that doesn't come back to them. They look at recidivism rates, not admission rates and readmission rates. So the incentives are so siloed in and of themselves because our systems are so siloed. We're not incentivized to work together. And so we've got to get around some of that and figure out innovative ways to tie together all of these systems, including criminal justice, in order to have incentives for the entire community aligned more effectively. And I don't have the answers to that. That's a big question. I'm certainly not the expert on that.
Ladies, state or national examples where you've seen promising practices?
Yeah, so there's some interesting work happening in Philadelphia right now where there's a partnership between local government, kind of the educational institutions, and then also healthcare. I can try and find more information about that to share with you because it's an interesting civic data example. And then I think, there's a lot of work being done to better understand incentives, both from a financial lens, but also just from the data infrastructure being able to report out outcomes that most matter to that sector, right? And that's not to say that that sector doesn't care about coordinating with the other sector, but I think, I'll just use myself as an example. Most of the time when I connect with friends in similar justice spaces, I'm like, we're doing epic integration, and we're looking at how social determinants are changing health outcomes, right? And most of my friends are saying, and colleagues are like, that's great, and they're in the education space, and then they kind of go back to their work, right? Because what they need to report on are third grade literacy, graduation rates, and reduction of chronic absenteeism, right? And so, it's interesting to me when I look at data infrastructures that allow data sharing, but also maybe some interesting ways that you are able to address multiple outcomes happening. So for example, like I think about the downstream effects in education being a social determinant and then health as the outcome, but for a lot of my colleagues in education, they're interested in how asthma perpetuates chronic absenteeism, right? And then that affects their own achievement gap kind of outcomes, right? And so I think all that to say, how do these infrastructures get set up in such a way that it's not just about incentivizing participant to a single stakeholders and driving the measurement, but also really what it takes to have multiple forms of measurement such that every player, right, in a cross-sector system sees value, not just in the heartfelt value of we all need to work together, but in the just day-to-day value of I need to report out on these things because that's how funds are distributed for my sector, right, and to do good work in my sector.
I've heard a lot, sorry, Louise White, I'm one of the Chief Nursing Officers at Sharp, and this has been a great conversation, and I'm hearing lots of discussion in regards to all the social industries and their involvement and struggles to make this all work. But is there any work going on with industry? The industry is causing a great deal of these challenges, and is there any work going on with industry's accountability and contributing and working? So, for example, you're looking for rides. Uber, you can work in the city, but you need to be riding the homeless to their job interview if you're going to work here. You know, all the IT industries, all of these industries, is anybody working with them to participate in these challenges?
Detail. I think industries are working on this. Oftentimes what we see is they're in different rooms than all of the public sector innovations. And so I would love to even just understand what it looks like to convene some of the industry innovators with the public health as well as social service innovators, because there is disruption happening in each, but you know, there are points of alignment and also points of, I think, a difference in maybe value or purpose, but I think there's a lot of places where there can be more synergy, and so just in a very simple way, yes, and also in a separate room, and so how do we get everybody into the same room?
And is the question, are you referring to the accountability of large multinational companies in contributing to some of the macroeconomic issues that are driving homelessness and wage inequality? Is that income inequality? Is that what you're talking about?
Correct.
Okay. That is a big can of worms to open. That's a huge can of worms to open. I would say I'm by no means the expert on this, fully acknowledged, but in the work that I do and the circles I run in, I'm starting to see that is changing. I mean, you can see that Apple has recently put a large amount, I think it was $2.6 billion, as I remember, into efforts to address housing shortages in the Bay Area, recognizing explicitly that they are a part of creating these problems. So I think that we're starting to see acknowledgement of that and investment in that, and some of those profits being returned to the community to address the very issues that sometimes these companies help drive. I think it's starting to change. Probably with recognition that if they don't, then governmental regulation and various policies will start to change, and it won't be in their favor at that point.
I asked Dimitri if I could quickly not just ask a question, but make a couple comments, and I feel like I know almost everybody in the room, but just in case I don't, my name is Nikki Fentides. I serve as the county's chief medical officer. First, I want to say thank you. Thank you so much to the Hospital Association for elevating issues like this. I do think it's amazing, and there are a lot of imposters in the room today who are not health system folks. We've got payers, lots of us from the county here, and this is a very germane and challenging topic. And I just want to tie a few loose threads. Earlier this morning, when I asked Nick the question about trust, Gina, I was getting exactly to that point, because the whole CX concept, I think, is something that's very relevant to us, but how does it apply to a population like this? And how does it apply in the context of what I call TC, which is trust capital? And I do think that we are an innovation zone. We have incredible tools with 211, with ConnectWell, with Health Connect, with a lot of resources. We also have a lot of best practices going on. But there's the reality of us being a pluralistic environment with multiple payers. And I do think that a lot of those best practices and the different initiatives, Jeff, which you so nicely summarized today, are causing some confusion, because there is the population. I was fascinated by how thoughtfully, Jeff, you tied this discussion in with the experience of Project 25, where there was that high touch, that high trust, hands-on experience with a clearly identified subset of humanity. And I do think you mentioned it in the introduction, Bridget. We're going to be in a very interesting place now in terms of state trajectory. We do have a couple key participants from San Diego. One of them, my staff member, is Dr. Jen Tudor, who's going to be on one of the key work groups convening next week. I do think that we need to kind of come to terms on consolidating some of this individuality between case management, care coordination that's going on at the system, institutional, payer, government, CBO level, and look at having a regional high trust capital, high hands-on approach with a subset of this population that we can take to scale. I really think with this population, the client experience is one thing, but adding that trust enhancement to that equation was exactly what was in my wheels earlier today as I knew this discussion was going on. So I just wanted to close that loop. And again, a heartfelt thank you to all the health systems, not only for hosting, facilitating, and prioritizing this issue, but also allowing so many of us who are not health system folks per se to be part of the discussion. Thank you.
Of thoughts, reactions from you folks based on even what was just said.
Some themes, and thank you, Dr. Nick. We heard and we have been kind of walking through local, regional, national, and I gave Jessica that option in her particular experience, but now I'm going to give the option to all three of you. Wave a magic wand. You've got a wide variety of partners here in the room. What does it look like in an ideal scenario? In one or two crisp sentences, what does ideal look like? We've articulated the challenges, we know what some of the steps might be, but what does that look like?
So a information exchange platform that functions, has high quality data, and allows individual care providers to not have to worry about trying to figure out how to get the data they need, but focus on the person in front of them to provide individualized patient-centered care.
Yeah, exactly what I was thinking. A clean system that works together so that when we do impact the individual, they feel like they're fully cared for as a person and that they're seen as a person and that they receive the best outcomes possible so that they can live their lives.
All of that. And for me, communities not only have access to their data, but are partners in interpreting the story of that data and in leveraging those data for change at a systems level.
Ladies and gentlemen, thank your panelists, and I thank you. I hope you're walking away with lots of aha moments.